All right, good morning, everybody. We're going to get started in the interest of time. I just really wanted to thank James Robinson and Tali Mejicovsky for making this Grand Rounds possible. It's in honor of their son, Nadav Robinson. And they have continued, just like Nadav, to seek to educate us through events like this and through James's book more than we expected. And Tali is going to say a few words before we get started with the speaker. Thank you.
Thank you, Miwa. Sorry, Dr. Geiger. Good morning, I'm Tali. It's James. This is the 7th annual Grand Rounds in memory of Nadav. I'm just going to take a moment to share a few words and also to explain how Dr. Ware has come to join us this morning. When most parents find out that their baby has been diagnosed with a CHD, they dive headfirst into understanding the diagnosis and the plan. They might research the mortality for their specific condition, but mostly their focus is on looking after their baby as best as they can. If parents do stop and think about how this may have happened, they might take comfort in learning that spontaneous genetic mutations play a significant role in many cases. However, somehow spontaneous mutations are okay, but inherited ones are not. Our son Nadav was born here at Sinai in 2011 with heterotaxy, single ventricle physiology, and underlying PCD. He was beautiful. He was a fighter and an old soul and a free spirit with a wry sense of humor. James and I didn't have any time to think about the how until 4.5 years later. We were too busy looking after him and his twin and his older brother, and we had a fateful trip around the world. It wasn't until October 2016, when Nadav was an inpatient at CHOP, that we were asked if he could participate in genetic testing as part of a CHD study. And when his results came back, then the rest of us also got tested. And what we discovered was that Nadav and his older brother were both homozygous in the DNA H5 gene for a rare sequence variant. See me later to find out the specifics. And that was known to cause primary ciliary dyskinesia and heterotaxy. And while we'd never considered Nadav's CHD was due to a spontaneous change, we also didn't expect to discover that both James and I were carriers for the exact same mutation and that mutation had never previously been reported. This was shocking. We didn't know really what to do with this information. Typically, knowing the genetics might lead to a change in a treatment plan or a personalized care if possible. But in our case, the test results would have no bearing. We were no longer having kids, and Nadav had moved well beyond the plan and was into complex care. We were able to suggest family screening to relatives, particularly as a cousin had just had a baby also with PCD, dextrocardia, and situs inversus. And I also considered whether I should suggest that DNA H5 be included as part of the Ashkenazi Jewish genetic testing panel. So please let me know after the talk if I should do that. I never did. So it's been just over 8 years since Nadav died, and we're still in awe when we think about how embryos develop and the genetics behind heterotaxy, but particularly PCD in regard with our older son. It's extremely important for this topic to be discussed for clinicians, yes, but also for parents. An understanding of how and why mutations occur and lead to congenital heart defects should be part of the diagnosis and care plan, and hopefully leading to better outcomes for our kids. So it's in this spirit that we invited Dr. Ware, and we're privileged to have her present to us today. And as I say each year, our aim with this Grand Rounds lecture series is that we should all come away having learned something new, especially something that we didn't realize that we needed to understand. So thank you so much to Dr. Ware, to all of you for joining us today in person and also on the Zoom. Thank you.
Thank you, Tali, and thank you, James, for supporting this Grand Rounds. So it's my pleasure to introduce our speaker, Dr. Stephanie Ware, who is remarkable, as you're about to hear. So educationally, she did her undergraduate education at Butler in Indiana, then went on to get MD and PhD degrees at the University of Cincinnati, and then moved south to Baylor and Texas Children's, where she did a residency of pediatrics and a fellowship in genetics. And I think at that point started doing some of her cardiovascular genetics work. That's where certainly she came to my attention. She was involved with a gene called ZIC3, which is one of the first that we've known in humans, particularly, that is responsible for heterotaxy. After completing her training, she moved back to Cincinnati, where she was for the next decade, and quickly rose through the ranks to full professor. And then in 2014, she moved to her current institution at University of Indiana in Indianapolis. I hope I got that right. And Riley Children's. There, she's again continued to rise through their ranks, and currently has an endowed chair, the Joseph C. Christian Chair, and she's also professor of the Department of Medical and Molecular Genetics. And I believe she's been leading that department for roughly 2 years, the genetics department for 2 years now. And she's done a lot of other leadership roles there as well. She's very accomplished, as you would expect for something like that. She's been elected to the Society for Pediatric Research, the American Society of Clinical Investigation. She's been well funded by NIH for her entire career, basically, has published a lot of important papers, and has mentored a lot of people, and is a wonderful person. I would say when Tali and James approached me through Howie and said, like, okay, we want somebody who can talk to this area of cardiovascular genetics, who's the one? Stephanie was the obvious choice. And I'll just say aside from the fact that she's particularly knowledgeable around the topic we're going to hear about this morning, the reason she stands out is the way I at least think of our field, cardiovascular genetics. There are 3 areas, which is problems of muscle, problems of how the heart gets formed, obviously congenital heart disease, and problems of arrhythmia. And there are lots of experts around. She's like the only one who comes to mind who's got 2 of those 3 areas covered. Pretty much everyone else, including me, is only focusing on one. So she really is a standout in our field. And it's been a privilege to have her as a colleague over the years, and I'm so glad she joined, and now I'm looking forward to your talk.
Thanks so much for that kind introduction, and for your introduction as well. It's just really an honor to be here, to be able to talk to you. And heterotaxy is, an area that's near and dear to my heart. For today, I am choosing to talk about congenital heart defects more broadly for, the trainees and the audience, but the genetic evaluation of congenital heart disease and heterotaxy is something that's really important to me as a clinical geneticist. So hopefully I can impart to you today a little bit of the sort of underlying rationale of why I think it's so important clinically that we continue to push forward and make sure that all of these children get the genetic evaluations that they need. So my objectives today really to make sure that we're kind of all on the same page in terms of what genetic testing options are available right now, and kind of review the types of diagnostic tests, their benefits and their limitations, to make sure that everyone is aware of the standard guidelines that are out there in terms of recommendations for testing for congenital heart defects. And then I'm going to provide some data about work that we've done at Indiana University, trying to get at the question of really what is the clinical utility of genetic testing. And then the last part, I'll focus specifically on heterotaxy, because of course, heterotaxy has often complex congenital heart defects as part of it, but it's a little bit of a special condition as well within the broader group of congenital heart defects. So when we think about the genetic causation of congenital heart disease, we've been very good at understanding that there's an association between genetics and congenital heart defects for a long time. And if you think back, 4 or 5 decades ago, the classics is Down syndrome, and recognizing that babies with Down syndrome have an increased risk of heart defects, especially AV canal defects. And so what's shown in the pie here is that we have our aneuploidies, so trisomy 21, 18, 13. And then as we got more sophisticated in genetic testing, we began to be able to see smaller changes in the chromosome. So things like 22q deletion or DeGeorge villocardiofacial syndrome, Williams syndrome. And then there are conditions, genetic syndromes that are caused by point mutations or smaller changes within the gene. And there's at least 100 other syndromic causes of congenital heart defects. And so that makes up about, at a minimum, 25% of patients with congenital heart defects. And that's just based on epidemiologic studies. The best one in the United States was done in the early 80s, the Baltimore, Washington infant study. And national registry studies from other countries have shown kind of similar proportions. And so then that leaves, about 3/4 or 70% of infants who have apparently isolated congenital heart defects, not part of a larger syndrome, but we still know that there's a genetic basis to their heart defect. And so we have an interest from a research standpoint in trying to understand that. But then from a clinical standpoint, this definition of what is an isolated heart defect versus what is a syndrome is something that I have become fond of saying, well, it's a little bit in the eye of the beholder, especially in a newborn, where it can become very challenging to distinguish some features that may become apparent later. So considerations in genetic testing broadly, not specific for congenital heart defects, relate to why should you test, when should you test, who should you test, and then actually how to pick the test and how to go about doing it. And there are a lot of nuances to that. And for my talk today, I'm really focusing on infants with congenital heart defects, because I think depending on the age that you're talking about, the recommendations for testing might change slightly because you get more information, you have more medical history, developmental history, so forth, in an adult, for example, with congenital heart disease than in infants. So in an American Heart Association scientific statement that first came out in 2007 and then was revised in 2018, it was outlined really at least 4 main reasons why you should consider genetic testing in congenital heart defects. And the first is that there may be other important organs that are involved, so it would allow you to be proactive in either surveillance or management. Secondly, there may be prognostic information in terms of clinical outcomes. Third, there might be important genetic reproductive risks that you would want to convey to the family or family members, already alluded to earlier. And then there may be other family members that should receive genetic testing. And so if we just talk about mechanisms of genetic disease, this is a karyotype, what our chromosomes look like, and at the highest level, looking at the number of chromosomes, that's kind of our baseline test, the abnormal chromosome number, or aneuploidies. And then if we zoom in on that and we look from the chromosomes to the genes, we can do a chromosome microarray test, which allows us to look for smaller deletions or duplications, also called copy number variants or CNVs. And then finally, at the highest resolution level is actually looking at the DNA strand and looking at base pair variation. And so it's important to, sort of understand that, because that feeds directly into the type of genetic testing that's available. So when I talk to families, I talk about the idea that our genetic information is organized as in textbooks or encyclopedias, when you used to have the, hard copies of encyclopedias, with all of the information on pages, and doing a karyotype or chromosome analysis would be analogous to walking in the room, being able to see the books on the shelf. You can count the number of books and see that it's the right number. And at a kind of broad level, you can see whether they're the right height and the right thickness that they should be. So chromosome microarray then gives us a much higher resolution, and it's analogous to being able to look at every page and every paragraph of every page and see, are all of the paragraphs there? Are there any paragraphs that are missing? Are there any paragraphs that are extra? And chromosome microarray testing first became available clinically in 2005. And by 2009 and 2010, you see here that a number of professional organizations were recommending it as first-line testing over chromosome testing. Molecular genetic testing, then, to continue the analogy, would be more similar to doing a spell check and reading the words on the page. And so you're looking to see if there are any misspellings, if there are any typographical errors. And so these two tests, the chromosome microarray type of test versus molecular testing, they're really complementary, and they're not completely mutually exclusive, but you get different information from them. So for example, if there's a misspelling, you're not going to pick that up by chromosome microarray. And by the same token, it can be challenging sometimes to see that because we have two copies of every gene, it can be challenging to see that you have a complete copy missing when you're doing the spell check. So as I mentioned, the chromosome microarray became available in 2005, and then the broadest molecular testing, exome or genome testing, exome testing became clinically available in 2011, and that's a test where you're able to look at all of the genes and do that spell check for every gene. And then genome testing is doing genes and the non-coding regions as well. So examples of some disorders with cardiac involvement where a chromosome microarray is not going to pick up the cause would be common conditions such as Noonan syndrome, common from a geneticist perspective, Noonan syndrome, Alagille syndrome, Townes-Brocks, Holt-Oram, Charge syndrome. These are all things that if you do a chromosome microarray and it's normal, it does not mean that the child may not have one of these conditions. And then again, when we talk about the types and scale of genetic testing, and from a molecular standpoint, just to give you an idea, it can go from the smallest scale where you have in a family, for example, DNAH5, you have a known genetic change or variation, and you can test a family member looking just for that specific change. That's kind of the most detailed look all the way to the genome, which is rather than looking at one single base, you're looking at 3 times 10 to the 9th million base pairs. So a broad difference in scale. And so, as I mentioned, there are a number of guidelines for genetic testing and congenital heart defects. In 2010, there was this consensus statement saying that chromosome microarrays should be offered to any patient that has developmental disabilities or congenital anomalies. And then there was the revised statement in 2018, which gave even kind of more detailed guidelines or things to consider with regard to genetic testing. And then finally in 2021, this position statement came out saying that exome or genome sequencing should be considered for pediatric patients who have congenital anomalies or intellectual disability. So one of the things that then has been challenging to me, I had been working on many of these things in the research lab, and I guess I thought that they would sort of naturally and easily translate to clinical care. And then, what I was finding in my clinical world was that just like the testing wasn't being done, it wasn't being offered for these patients. And so that has led me to really try to understand better why are we not testing, who should we be testing, and why is there still lack of consensus and difficulty in uptake of this within the field. So, and this initially started actually when I was at Cincinnati, and we had put in place sort of a standardized protocol for evaluation of patients in the CVICU. And our intensivists were asking us to do more. And we started by just looking at, well, how well are we doing the testing right now? And what we found was that there was really a significant underutilization of testing because we were testing 25% of the infants with congenital heart defects. And I showed you at the beginning that a minimum of 25% have a syndromic diagnosis. So unless we're perfect in being able to ascertain which patients we should be testing, we were going to be missing some cases. And so we put in place a protocol, and we did that. And then also one of my now colleagues then was at Medical College of Wisconsin, Elle Geddes, put in a protocol at Medical College of Wisconsin where she was working that actually showed that you can, by standardizing this, you can both improve the diagnostic rates but also reduce costs. So when we put in place our protocol, we found that in infants who had extracardiac anomalies, so they had a heart defect plus some other birth defect, that about 40% of the time we were getting a diagnostic result. But when we tested patients with just isolated congenital heart defect, we were still seeing about 16% that had a diagnostic result. We had a lot of questions about, well, is that cost effective? But then Dr. Geddes showed that actually you could reduce cost by just eliminating the redundant testing. And when we had looked at testing at our institution, and she did the same thing at her institution, what we found was that the patients who did get testing often got multiple redundant genetic tests. So we had patients in our CB ICU who were getting a chromosome analysis and getting FISH analysis and getting a chromosome microarray analysis. And those are really all redundant tests which don't lead to any additional information. And so by eliminating those extra redundant tests, you could actually do more cost-effective testing. So recently, we did this multi-center study, 5 centers who had participated in, we have a registry that collects patients with abnormal microarray results and abnormal echocardiograms. So we used those centers, and we just wanted to see, what are the genetic testing practices at these institutions who all have champions there for cardiovascular genetics. And we chose to do a time period between 2013 and 2016 because this was really before exome sequencing was widely being used clinically, but it was long after the first recommendations to do chromosome microarray as standard of care. So we thought, we'll kind of catch that sweet spot when people really shouldn't be confused about what to do. And so we used the STS database to identify patients at all of the sites so that we had sort of standardized ascertainment. And by doing that, and we looked at everyone under 14 months of age and followed for at least 2 years post-surgery. And that was almost 3,000 children that we looked at. And so we broke it down into patients that had apparently isolated congenital heart defects, which was about 80%, and then patients who had a congenital heart defect plus one other birth defect, multiple congenital anomalies, and so that was about 19%. And what you can see is across the sites, there were statistically different practices with regard to genetic testing and genetic evaluation. So across all patients, ranging from a low of 42% that had testing of these infants to a high of 66.7%. And as you might expect, in patients who had multiple congenital anomalies, testing was more common or was higher than in individuals with isolated congenital heart defects. So, this really showed us that even at sites that are thinking about this a lot, there's a wide variety in terms of practice. So a huge degree of practice variation still. And this is just looking at that data by the type of test that was ordered. And what you can see, I think, it's back. What you can see is that we have the highest rate of chromosome microarray testing, so that's good. We're doing more chromosome microarrays than we are doing just regular chromosome analysis, and pretty limited molecular testing at this time, which is probably appropriate given the years we were looking at, but very high yield when we did it, which says that someone's thinking about a specific diagnosis in those cases where it's done. So what are the limitations and barriers to understanding, why the uptake of genetic testing has been a bit low and whether we are testing the right patients or not? I think the rapid changes in genetic testing with kind of constant evolution in terms of the panels has made it very hard to do evidence-based studies to provide information. Also, diagnostic yield has been used as a surrogate for clinical utility. And I would argue that diagnostic yield saying, well, I have a 70% hit rate when I do this test is not really the appropriate marker of the clinical utility. Because if I want a diagnostic yield of 100%, I can only test patients with Down syndrome, right? Then I'm going to be perfect in my ascertainment, but we know we're going to miss a lot of patients who would benefit from genetic testing. So I think it's an important thing to to record and to pay attention to diagnostic utility, but we shouldn't confuse it as being clinical utility. And then finally, most published literature are still single institution reports, and there are very much sort of a cherry picking approach to how did we ascertain our patients, how do we know who we're testing, and it's quite variable from institution to institution. And this idea of syndromic versus non-syndromic as being somewhat in the eye of the beholder. So since I have been at Indiana, it's been 10 years now, and it has provided an opportunity to really provide sort of a systematic approach to testing in infants. And so when I started there in 2014, kind of halfway through the year, we put through our NICU guidelines committee, presented the evidence why chromosome microarray should be a test done in any infant who was hospitalized because of their cardiovascular malformation. So this is not patients with kind of simple VSDs or ASDs who are not going to be an inpatient in the newborn period unless they have other things going on. These are patients with more complex malformations typically, or a more simple heart defect along with other anomalies. And so what you can see is over the almost decade that we've done this, we've increased the number of patients that are being tested, and we've actually had sort of 3 eras that we've gone through. From 2014 to 2019, chromosome microarray was our sort of test. Every patient got a genetic evaluation and got a dysmorphic evaluation. And then if molecular testing was indicated based on that, it would be done, but everyone got a chromosome microarray. And then from 2019 to 2022, we went to kind of a broad congenital heart defect panel that also included copy number variants. And then starting in the summer of 2022, we've been doing rapid genome testing since then. And the diagnostic yield over the eras has increased because of that. But what we've seen is that the increase is really in the molecular diagnoses. So the cytogenetic diagnoses, these would be the deletions or duplications, have really stayed pretty stable at 15 to 18% since 2014. And then we've gotten this increase based on the molecular diagnoses. And we also looked based on the type of heart defect. And for this, we've used, there's many different classification systems to try to kind of lump different types of cardiac defects. We've used the Bato classification because it's more of an anatomic embryologic basis. But you can see that there are certain types or classes of heart defects that are going to have a higher genetic yield. So for example, conal truncal defects, this would include the majority of your patients that have 22q11.2 deletion. We have a higher diagnostic rate in that category, as well as our left-sided LVOTO defects. And when so we looked at the stratification by extracardiac anomaly for sort of that first era from 2014 to 2019. And at the top, I just show kind of the numbers in each category, and then the summary of our findings is below. And so what we found is that, yes, the congenital heart defect type did influence the overall diagnostic yield. And that dysmorphic features or extracardiac anomalies increase the diagnostic yield, but actually 6.5% of patients without any suspicion of a genetic condition by a geneticist still had a diagnostic chromosome microarray. So we did find that incorporation of a geneticist increases the rate of diagnoses, and that molecular testing is additive. And as you might expect, that infants with extracardiac anomalies, again, you have a higher rate of genetic syndromes in those, but the overall diagnostic rate was 17% for that kind of 5-year era. So we wanted to look more specifically at those patients who were thought to have isolated congenital heart defects. And this is kind of, again, showing 3 different testing eras of chromosome microarray, a large panel, and then genome or exome. And what you can see is that really the increase in our diagnoses are coming from those who don't have extracardiac anomalies, so those who have isolated congenital heart defects. And we see an increase from the 2014, 2018, where we were at 7.7%, up to 2023, 19.7%. And so we've done some modeling looking at, well, what is the probability of identifying a genetic diagnosis if we look at dysmorphology? So we wanted to kind of separate this idea of extracardiac abnormalities from dysmorphology. And part of the thought for this was when we began to, early on, to try to categorize patients into one or the other, what we found was that often patients with Down syndrome would end up falling into our isolated congenital heart defect group because they had a heart defect and they had dysmorphic features, but they didn't have another birth defect that went with it. And it's like, okay, well, this isn't right. We have to incorporate some of the dysmorphology into this as well. And so we started kind of separating those groups out, and we just made a dysmorphology score for, because all of these patients had an evaluation by a geneticist, and over the period of time, there were kind of 10 different geneticists, and so we sort of evened out if there were differences between geneticists. And what you look at here is then just the modeling of stratifying the dysmorphology and the extracardiac abnormalities. So what it shows here, if you have a patient that is not dysmorphic at all, if they have an extracardiac abnormality, your likelihood of finding a genetic condition when you do testing is about 24%. And if they don't have an extracardiac anomaly, then you're more in the range of 5 to 10%. As you increase the number of dysmorphic features, these kind of streams start to cross each other. And that's because if you get out to, say 15 dysmorphic features, almost all of those patients end up having extracardiac anomalies as well. So those patients usually have multiple congenital anomalies and dysmorphic features. And at that point, you end up with, upwards of 70% likelihood of a genetic diagnosis in those individuals. And I think that this is kind of helpful, especially when you have a newborn, to be able to sort of risk stratify and discuss with families if their child is very ill, what it is you're thinking about, what things that you need to do some testing to rule in or rule out, and what your overall level of worry is about the underlying cause for the patient. So the other thing, I'm going to flip through these and show the curve. We did something called the decision curve analysis. And this is something that's used in population health to try to understand sort of the threshold for offering testing, for example. So decision curve analysis has been used for colorectal screening, for example. What age should you begin offering colonoscopies? And the idea is that you establish a certain risk threshold that you're willing to tolerate. And so it's really agnostic into terms of what is right or wrong, and it's more what is acceptable, what is an acceptable risk to you. So we wanted to look is the extracardiac abnormalities a reasonable screening to decide to offer genetic testing, or is a test all approach better for these infants in the CVICU? And it really comes down to, well, what level of genetic diagnoses do you think it's acceptable to miss? And so we know that if we were using extracardiac anomaly status as a screen, that we would miss 78 of 580 patients that had, isolated congenital heart defects. So about 13.4% of the patients we would miss. And so what you see here in the red line is test nobody. If you test nobody, you're not going to find anything, right? If you test everyone, that's going to be the best choice if you say that 14%, I think, is a threshold that we should not miss. I want to detect everyone that has a 5 to 10% likelihood of having a genetic explanation for their heart defect that is identifiable and clinically relevant. So if 5 to 10% is your threshold, then a test-all approach is going to be better. If you say 20 to 25% is my threshold, then testing patients only with extracardiac abnormalities is going to be the best approach. And I'm going to get to heterotaxy at the end because it falls into really a different category with all of this, because with heterotaxy, almost by definition, you've got multiple congenital anomalies. So summary of the lessons learned from this inpatient genetic testing protocol. So we know that testing historically has been underutilized and maybe not most cost effectively applied, and that a systematic genetic evaluation will increase the diagnostic rate, and it does alter management. Comprehensive testing identifies patients not suspected of having a genetic basis for their congenital heart defects. And it's really important to distinguish between extracardiac anomalies and dysmorphic features. So the test options have increased significantly over the last decade, so we are still very much in this emerging area of what is going to be the right test to offer, especially in infants. And in predicting positive genetic testing results, extracardiac abnormalities is the largest contributor. And so, it definitely, when you see that, there's an increased risk of a genetic condition in that patient. But it shouldn't be used to rule out the possibility of a genetic syndrome or a genetic diagnosis. And a dysmorphology status is secondary to that, contributing about an extra 15 to 20% with an odds ratio of 1.2. So these can be used to risk stratify patients, but they shouldn't be used to exclude from testing, because up to 10% of patients with no dysmorphic features and no extracardiac abnormalities are still going to have definitive genetic testing results. And as I mentioned, population health tools such as decision curve analysis can be applied to congenital heart defects to help us better understand where we should make those lines. So finally, with regard to outcome, then, we're beginning to look at this now that we have a little bit of a bigger cohort. And, my pediatric cardiology colleague, Ben Landis, has done some work looking at our inpatients. And, we did find, as expected, that in those who have isolated congenital heart defects but have mortality related to their operation, that a big distinguishing factor was that they had a genetic abnormality. And then we've gone on to look at sort of medium-term survival following neonatal congenital heart surgery. And so this was using a cohort of 361 infants, neonates actually, and 299 had CMA sent. Again, this is kind of from our early era. 62 did not have CMA sent. And then of the 299, 49 had a genetic diagnosis, 250 had no genetic diagnosis, including CMVs of uncertain significance. And so looking at the outcome of those individuals over 1,000 days post-operatively, what you see is that by the time you get to that medium-term survival, you are starting to see some distinction between those that have a genetic diagnosis versus those that don't have a genetic diagnosis. Although within the first 100 days of life, those that curve is really overlapping. So there's definitely a lot more to be teased out here. I think the type of genetic finding obviously is going to make a big difference. Combine that with the type of cardiovascular malformation, and those are going to take large data sets, I think, to really begin to tease apart outcome. So summary to that, before kind of moving on to heterotaxy as a special case, is that I think the rapid changes in the genetic testing landscape have been challenging. You really need buy-in from an institution in terms of how you want to approach this as a group. There's a number of different specialties that are involved, and there's not one right way to do this. So I do think that genome sequencing now is the best test for infants with congenital heart defects because a genome test gets you both the chromosome microarray and sort of the exome level sequencing. Exome sequencing has some problems with picking up all types of copy number variants. So, and really the cost of genome versus exome is identical, essentially. So I think genome is the better test. We're starting to begin to see insurance understand that and approve that, but it's very much an evolution. And so I do think that a systematic approach is the best answer. And so if as an institution you decide not to do genome, if that's not your threshold, then I would say chromosome microarray or something like that, doing it systematically would be a benefit. So then let's talk a little bit about heterotaxy, because it's a sort of a special type of congenital heart defect, because it's really a disorder, what I call a disorder of laterality, which has to do with how the left side and the right side of the bodies get assigned during early development. And we know that most patients with heterotaxy will have cardiovascular malformations, but in order to call it heterotaxy, there have to be other findings as well. There we go. So the epidemiology of laterality defects, this has been published work from a couple decades ago, and they have really described the birth prevalence and the epidemiology. And one of the interesting things to me is that with this study, I recognize that we don't have a common nomenclature for heterotaxy, and what one specialist considers heterotaxy, another specialist might not. And part of the reason that I realized that was, in my way of thinking, you have sort of what we call situs inversus totalis, which is the normal arrangement of your internal organs. You have normal situs, you have situs inversus totalis, which is the mirror image reversal of all of your organs. And then you have heterotaxy or situs ambiguous, where the organs are a little bit randomly assigned with regard to the left-right axis. And so for me, situs inversus totalis meant that a patient had dextrocardia but didn't have any intracardiac structural abnormality. And you can see from this National Birth Defects study, their definition is that you can have simple or even complex heart defects as part of it. And they do a very nice job of really outlining how they categorized heterotaxy, requiring at least 3 features. They have 8 different groups, and we don't need to go through it all now, but basically a heart defect plus at least 2 other organs or 2 other signs of a laterality disorder. And so, I think we published these guidelines recently about an approach to management of children with heterotaxy, and I brought up this question that I'm not sure that we're all talking about the same thing when we use the term heterotaxy. So I think most clinicians would agree that if you see, for example, a patient with an unbalanced AV canal, interrupted IVC, they have asplenia, they have a right-sided stomach, a midline liver, that is heterotaxy. But what about if they have this complex malformations, door of LTGA, and they have a malrotation, but they have normal situs of their other organs? Is that heterotaxy? Or we go with a more mild heart defect, just an atrial septal defect, but they have a left-sided liver, and we don't know the spleen position yet. Is that heterotaxy? And then finally, just a malrotation and polysplenia. In my mind, as a basic scientist, that's heterotaxy, because that's a left-right patterning abnormality in early embryonic development. But most clinicians in the audience would not call that patient a heterotaxy patient. So I think we have some problems in even understanding what our cohort is. So does this matter? I would argue that it does matter. We need to have a common language to describe a condition. The ICD-10 codes for heterotaxy are not precise. And that makes it very hard to do studies across institutions because we wouldn't even all enroll the same patients. It's very difficult to establish registries. It's difficult to do natural history studies. We can't study outcomes because we have different conditions. We have missed and delayed diagnoses and evaluations because of this. If it's not called heterotaxy, nobody's going to look at spleen function. And then the patient family experience is really not to be discounted. I have so many families who tell me, I always thought it was just this. And then when she was 8 or he was 10, we found out that, there was no spleen, and that explains all these recurrent infections and so forth. Families also describe their sense of isolation when heterotaxy is diagnosed in terms of, well, we've never seen this anatomy before. And I think that's very isolating as opposed to saying, well, heterotaxy is a condition where we can see a lot of different anatomic abnormalities, but heterotaxy itself, yes, it's rare, but it's not so rare. There's a community of families that have individuals affected with heterotaxy, and there are support groups related to that and so forth. And often what it does is it requires the families to really develop the medical sophistication to advocate for the child because they're the ones that have to inform the provider, well, that primary ciliary dyskinesia is associated with heterotaxy, right? And often providers don't know that. And so the family becomes sort of the surrogate for helping guide that medical decision making. So we know in terms of congenital heart disease that there's a strong genetic component, but we often don't realize, this is from a national study done in Denmark, that heterotaxy is actually at the top of the list in terms of the inheritance, if you will. And that is despite the fact that we rarely see heterotaxy recur within families, and that has been a bit perplexing. So I wanted to talk a little bit about what the biological basis for heterotaxy is, and then things as a clinician that you should think through when you see a patient with heterotaxy. So the biologic basis is, as I said, it's a disorder of left and right patterning, very early in development before the organs even form. You have the different axes of the body that form, and the left side and the right side need to have a blueprint, if you will, and there are gene pathways that control that blueprint. And there is this early embryonic structure called the left-right organizer, which has about 250 to 350 cells in it, and each cell has a single cilia on it, and that cilia rotates in a counterclockwise motion. And that is what actually generates the breaking of symmetry, and the fluid flows to one side, and that side becomes the left, and then the other side is the right. And if that doesn't happen correctly, then the left side doesn't really know it's left, the right side doesn't really know it's right, and at that point in time, the cardiac tube forms, and it's just a tube in the middle of the body, and it's very sensitive to these left-right cues because it has to undergo this complex folding process to turn from a tube into a 4-chambered heart. So if it doesn't know it's left from its right, it has a hard time doing that folding properly. And that's why so often patients with heterotaxy will have cardiac defects and will have complex cardiac defects, is because of that sensitivity to these left-right cues. So we know, because we know that cilia are involved at this early embryonic stage, we know that there's at least 3 different mechanisms, kind of broad mechanisms for heterotaxy disorders. There's cilia abnormalities. They're what we call cell polarity defects because that controls where the cilia gets placed on the cell. It starts out right in the middle of the cell, and then it actually has to rotate a little bit backwards, so it's like a third of the way down the hill. And if that doesn't happen right, then you can get heterotaxy. And then kind of downstream of that, there's these signaling pathways that have to occur normally. So if any of those 3 things go wrong, there's a possibility of heterotaxy. And in terms of the genetics of heterotaxy, basically you can see any type of inheritance pattern, X-linked, autosomal recessive, autosomal dominant, but far and away the most common thing that we see is not really a Mendelian inheritance pattern. It's probably oligogenic, meaning that there are multiple genes that contribute to this process. And if there is the right combination of susceptibilities, you kind of tip over a threshold, if you will. And current genetic testing panels, in addition to genome sequencing, there are specific heterotaxy panels, there are panels for PCD, and there are panels for ciliopathy conditions. So conditions to think about in newborns with heterotaxy really go back to these biological mechanisms. So ciliopathies are a group of disorders or primary or sensory cilia, and my next slide I'll show you what I mean by that. And then PCD, primary ciliary dyskinesia, we know that in individuals with PCD, that at least 12% of them actually have heterotaxy or situs ambiguus. We don't quite know if you have heterotaxy, what's the likelihood of having PCD. We don't have great numbers for that yet. And then there are syndromic forms of heterotaxy. This is not that common, but trisomy 13 in particular can have heterotaxy associated with it. And then 22q11.2 deletion. Again, not common that you see heterotaxy, but there's a non-random association there. Most common is what I would call isolated heterotaxy, meaning that none of these other things are found, and you can do a little bit of risk stratification based on these buckets then. So here's what I mean by primary cilia or sensory cilia. We've got basically three different types of cilia. You've got modal cilia. These are the cilia that we know of, like in our airway, that help with mucus secretions. And these are the problem. This is a problem when you have primary ciliary dyskinesia. These cilia don't work well, so they're not kind of moving mucus out of the lungs and out of the trachea. These cilia occur in big bunches, and they move. Then you have primary cilia, and these are kind of one cilia per cell, and these are really sensory organelles. They sort of sense the external environment. You find them on a lot of different cell types. And then this cell that we find at the left-right organizer or embryonic node is a very kind of special combination of these two, because it's a single cilia per cell. It's not a big bunch of cilia, but it does move and rotate, which is like the motile cilia. So it's its own special type. It's the only place that we know of this type of cilia. So these primary cilia, sensory cilia, lead to a whole constellation of genetic disorders that are rare diseases. Alström syndrome, Bardet-Biedl syndrome, there's different types of kidney diseases and also different types of structural malformations of the central nervous system that can go with these. Not very often do you see heart defects in this group of rare genetic disorders, but about 10 to 20% of the time you will, and less than 10% of the time you'll actually see situs inversus in these individuals. So we know that diseases of the primary cilia can overlap with this biological mechanism, but we have more to learn there. We know that there's this overlap between primary ciliary dyskinesia and heterotaxy. I sort of mentioned the data we have and the data we're still missing already. And then management. So what should be the management approach in patients with heterotaxy? Well, obviously, there's the medical and surgical management of the cardiac malformations, and that really primarily drives the prognosis for the child based on the severity. But those children should also have a head and abdominal renal ultrasound. They need evaluation of their spleen function because of the risk for asplenia or decreased splenic function, an assessment for malrotation, an assessment of the pulmonary status and primary ciliary dyskinesia, and then genetic evaluation, genetic testing, and recurrence risk counseling. So we published this a long time ago, 2009, and I'm sad to say that I don't think the numbers have really changed significantly since then in terms of what the yield of testing is. We just don't have really great data on individuals with heterotaxy and the different yield of genetic tests. What we do know is that your yield of finding an answer in heterotaxy is going to be much lower than it is in other types of congenital heart defects. We looked at copy number, we and others have looked at copy number variants also in patients with heterotaxy. And again, you do find some copy number variants, but much less than what you see in other types of heart defects. So in terms of clinical genetic testing for heterotaxy, really, it should encompass both copy number variants and single nucleotide variants. So I do think that genome testing is the best testing if you're going to do it. But you definitely should do testing for SIK3 because it's a gene that causes heterotaxy in probably around 3% of individuals. And it very much changes the recurrence risk because SIK3 is on the X chromosome, so it's typically boys that are affected. And most frequently, moms are carriers then. And so if testing for SIK3 is positive, then the recurrence risk is going to be 50% in males. And that's a big difference in recurrence risk versus sort of the epidemiologic recurrence risk, which is 3 to 5%. You definitely should test for genes that cause PCD because there's different management for that in terms of the respiratory therapy and prophylaxis for infection, and also because that's an autosomal recessive mechanism typically. And so again, the recurrence risk is going to be very different for PCD. And then if there are other things that this is like an unusual presentation of heterotaxy, you should just keep in the back of your mind that there are these other ciliopathies that are out there, that there's an overlap there sometimes that we don't completely understand yet. So where are we with our diagnostic yield? I think these are a little bit optimistic, but I would say clinical microarray, you're in the range of 15 to 30%, probably on the lower end of that. And with clinical sequencing, 10 to 20%, but those are really not completely additive. So I would say, overall, the likelihood is somewhere between 10% and 20% that you're going to get a positive result when you do the testing. I think a negative result is extremely useful for the reasons I've outlined, though, because you can rule out primary ciliary dyskinesia, which is going to have different management recommendations potentially. And you can also counsel very appropriately with regard to recurrence risks. And so, we're actively working from a research standpoint on trying to better understand other genes that may lead to susceptibility for heterotaxy. And so with that, I just want to summarize the last part, that heterotaxy really is a problem of laterality or a problem of left-right patterning. It can be X-linked, it can be autosomal recessive or autosomal dominant, but most commonly it's multifactorial. Clinical genetic testing is available. PCD is very important to think about. And then we have ongoing investigation. And so with that, I'll stop. Thanks for your attention.
I think we've got time for questions. I just ask you to repeat the questions.
Okay.
Not mine. So questions for Dr. Ware.
Excellent talk. I'm wondering, during the last part of your talk, if you think long-read sequencing can help unveil some of these molecular mechanisms that we don't know about yet.
Yeah, so the question was about long-read sequencing and whether that could help reveal some of the molecular mechanisms. I definitely think that's possible. I think that there are potentially some structural rearrangements, for example, that currently we're not detecting by genome. I also think that RNA sequencing may be helpful in some where there may be alternative splicing abnormalities that we wouldn't normally think of as important just from genome, for example, but we would, something on RNA sequencing, especially in the pathways that we know cause left-right defects, that could give us a clue as to what's going on. So I think there's going to be room for these emerging technologies and helping with the diagnosis.
In the first part of your presentation about the inpatient genetic protocols, when you call something extracardiac, I imagine a lot of that depends on inherently how much you search initially. Have you ever looked to see of the patients that were isolated, that got a genetic diagnosis, if there were extracardiac features that were then discovered?
Yeah, that's a great question. So it's about, again, how do we call something isolated? And if they're initially called isolated, but then later found to have other abnormalities, if we've looked at that. And we're trying to go through the data with regard to that now. It's very time consuming because you have to really find, well, when was the genetic test? What did you know when the genetic testing was done? And then, look after that in terms of when diagnoses. Most of the, because we're doing neonates primarily, I mean, the 90% are less than 30 days of life. And almost all of those have at least a head ultrasound and abdominal ultrasound. So we feel that, and sort of the dysmorphology exam. So we feel like we're picking up sort of the major things, but we definitely can be missing like spleen status, for example. So it's going to take us a while to go back through that, but I think it's an important thing to look at.
So we're at time, so I think it's okay. Please come up and yes, Dr. Ware, your question, if you have them. Sorry, join me again and thank you.
Thanks for your attention.